Good evening and welcome to the Healthy Living series. This is an event sponsored by Dartmouth-Hitchcock Health, and we're really happy that you could be here with us this evening. My name is Angelica Ladd. I work in external affairs here at Dartmouth-Hitchcock Health, and I'm going to help moderate your questions tonight. And we're really excited to have our Dartmouth-Hitchcock Nashua providers with us tonight. We have Dr. Sharon Silveira of Obstetrics and Gynecology, Dr. Charles Cappetta, and Eleanor Maguire, APRN of MSN APRN of CHaD Pediatrics in Nashua. So we're really lucky to have them tonight, and they're going to try to answer all of your questions. We'd love for you to send your questions. This is really important part of the dialogue tonight. And just a couple of housekeeping issues. If you want to send questions, just use the Q&A function. And if you could fill out the survey that you'll receive at the end of this event, that really helps us with programming, and we would appreciate any and all of your feedback. So without further ado, I'd like to turn it over to our providers so they can just talk to you a little bit about care in our clinic and how everything is shaping up right now. So I'm going to turn my video off, but please do send those questions and I'll chime in as we go along. So thank you for being with us tonight, and I'll send it to you, Dr. Silveira, to start.
Great. Hello. So this is one of my first times doing a webinar like this, and just so everybody knows, I don't see any other faces, so except for Dr. Cappetta and Eleanor. So I apologize if I'm missing anything. But I just wanted to say welcome and thanks for joining. I don't know how many people here are first-time moms or experienced moms, whatever that means, because we all know that yeah, every day is a new experience with pregnancy and childbirth and having infants. Oh, I can see we have 7 attendees, so at least I can start to see something. But thanks for joining us. So I'm thinking that most people are new moms. I don't know how far along you are in pregnancy, or maybe not even pregnant yet. So I just wanted to say that I have, with Dartmouth-Hitchcock for about 8 years. I love working for the organization. I hope that if you're a Dartmouth-Hitchcock patient, you stay with us, and if not, please come to us, because it's just a wonderful organization that's always working to strive for the health and care of patients in our community, and it's just a great organization. So the way our prenatal clinic at Dartmouth-Hitchcock works is that we have 3 MDs, myself, Dr. Bell, and Dr. Feltmate. And then we have 3 associate providers, a midwife, Susie Krasner, and 2 APRNs, Julia, she just changed her last name, so it's Stobel, and Emily Prue. And we work as a team. So a lot of times prenatal patients see the associate providers who are very versed in well women antenatal care, as well as a lot of the pregnancy problems that happen. But the MDs are available to see a patient throughout her whole pregnancy, or just here and there as needed as well. But we are very much a team approach. Some patients choose to see one provider the whole time, and other patients choose to just go with whoever's available. And we have a medical record and clearly indicate problems a patient might be experiencing on a problem list, as well as filled out in our notes. So we see women throughout the pregnancy. Usually it's about every 4 to 6-ish weeks until the 3rd trimester. And then in the 3rd trimester, it becomes every 2 to 3 or 4 weeks, again, depending on the patient. With COVID being a concern, you know, we do work with each individual patient in terms of how often the visits will be. So if a patient is comfortable kind of having a telehealth appointment in instead of coming into the office early on, we'll often do that, or later if they're an uncomplicated pregnancy, or if they feel most comfortable coming into the office, that works as well. We are, in terms of COVID, I'm sure there's some questions regarding that, but We temp screen everybody at the door. We require masks in the building. All the providers are masked, and we wear face shields for every visit. All the rooms are thoroughly cleaned between every patient, and we try to maintain social distancing in the building, including the waiting room and things like that, and feel that it's a very safe environment to come into the office. But we do know with COVID rates rising and everything that some people might choose not to, and as long as that's safe, we can offer telehealth visits. We have all the services we need in our office. We have the lab, we have ultrasounds available, we have NSTs available for women who might need fetal monitoring by putting the baby on a monitor and watching the heart strip. We have genetic counselors, and we also have a high-risk maternal and fetal medicine doctor who is in Nashua every Thursday, available all days a week for questions from us if needed, and patients can go up to Manchester for their appointments with the maternal and fetal medicine doctor as well. In terms of the delivery care, we do have a hospitalist model at Southern New Hampshire Medical Center. So this has been, I want to say about 5 years now, maybe a little bit over 5 years, that we have 4 primary hospitalists who are amazing, that staff L&D 24/7. And we have another level of providers on L&D as their second hands. During the day, it's often an NP, but at night, it's often a midwife, and sometimes the midwives are there during the day as well. Again, a team approach. So lower risk patient who has an uncomplicated course might, have a midwife involved for the whole delivery, or somebody who's got more obstetrical problems might need, more of that MD level care. The MD is there, but it's nice to have that multiple layer too, because if one person is involved with the delivery, there's always somebody else there to help. And then the 3 MDs from our office that I mentioned, as well as the MDs that are through foundations, are the rest of what we call the backup call. So that if things on L&D are really busy, there's another layer of help. That's my job today. I'm the backup call provider, so things haven't been so busy that I haven't been needed, and I've been over here doing telehealth visits in the call room, but I am available to assist a C-section, going on a delivery, go do an ER consult, or something else if needed. So again, I feel like it's a very safe place to deliver, which is important. Obviously, when you're thinking about where you want to get care and where you want to deliver, in terms of our multiple layers of providers that are available. People often wonder about, the chart, and do they have access? Do they see all the things I've talked to my providers about in the hospital? And yes, they do. Currently, Southern does not have Epic. They are moving onto Epic, so they're actually going to be able to see everything right in their computer system in the very near future. But right now what happens is they have access to Epic, so they can sign in, they can see everything, and as soon as you show up at the triage area, a copy of your prenatal summary is actually printed, so the doc or the provider seeing you has ready access to read it. As well as sign into the computer if they have to get more information. And in the future, they're all going to be looking at the same computer and just going to their Epic system and then our Epic system. So it's very easy, and the communication is seamless. When you leave, if they need follow-up, they always either call our nurses or send a message through our system to tell us what you were seen for, what kind of follow-up you need. So I feel like that's all very smooth. For patients that it's their first pregnancy and they need a C-section because the labor just isn't progressing normally, and that's what's advised, either because the labor stalled or there's fetal distress or something, the hospitalists on call do perform those C-sections, and again, they are amazing providers, amazing surgeons. If somebody needs a primary C-section because a baby's in breech presentation, or repeat C-section because they already had a C-section once and that's how they've decided to pursue the second delivery after counseling, Dr. Bell, Dr. Feltmate, and myself do schedule and perform our own scheduled C-sections. But if somebody goes into labor beforehand, we do have the team to take care of you in that setting. In terms of hospital protocols, of course, with COVID, things a moving target, but currently, you are allowed one support person to be with you for the duration of the stay. I believe they're still asking that that support person not leave the hospital. So we do ask that you bring all the things in with you from the car that you need, including the car seat, and that the support person kind of stays with you. They can leave the room to go to the cafeteria or the cafe, but not potentially leave the hospital. There have been extenuating circumstances, and people do understand that, and we try to make exceptions for extenuating circumstances if needed. In terms of, we do ask that everybody remain masked in the room when a provider, like a nurse or a MD or midwife or another provider comes into the room. Again, just as an extra level of precautions, all women admitted for labor do get a COVID test. But of course, you know, we don't know the partner's status. There's always the potential for a false negative or too early in the evolution of the course. So that's why we do ask that people remain masked when another provider is there. And the providers taking care of you will be masked and wearing face shields and things like that as well. I'm trying to think if there's, in terms of going home, a lot of women are choosing to go home postpartum day 1 from a normal routine vaginal delivery, but there's the option to stay to day 2 if there's any concerns, or if the baby needs to stay for any reason. Some people are just opting to go home because they're ready and because they do want to decrease the amount of time they are in the hospital setting now with COVID. And after a C-section, again, a lot of times in the past it was day 3, and now patients are really opting to go home on day 2, and we're not seeing any downsides from that, like people coming back and getting readmitted or feeling like they were sent home too early. And obviously, if anybody has an issue with blood pressures or bleeding or any concerns, we never are rushing people out of the hospital. I think that's covering the gist of everything, unless somebody can think of something else I have missed, or we can always circle back with questions.
I am not seeing any questions, so if Dr. Cappetta, you'd like to take over, and again, if anyone does have any questions, please feel free to enter them in the Q&A function, and we will chime in with those.
Well, thank you, Angelica. Dr. Silveira, that was a great summary. I learned a few things about the hospice and delivery service there. Thank you. I would echo what Dr. Silveira says, that I've been at Dartmouth now 30 years, down here in Nashua for 27, and my colleague, Eleanor Maguire, have done these Meet the Pediatrician, Meet the Pediatric Group providers for a number of years now. So it's our first time too doing this on a Zoom meeting like this. So bear with us. We're actually 6 feet apart. We are socially distanced, but we decided to take our masks off. Otherwise you couldn't see our faces. So what I was going to do, we're going to split up the newborn care a little bit, because it is a maternal fetal department, as we like to say. So it's wonderful to have our OB colleague. I tell moms, they do all the hard work, including the moms who do the most work. And then we just, we're there and catch the babies at the end. So that was my attempt at a joke, but there we are. So I hope you're enjoying tonight's festivities, and it's a fun thing to do. So our role in pediatrics has changed actually in the hospital. We have always rounded there, but like OB, pediatrics has become an outpatient department for the most part. So in fact, our department, which we'll talk about in a few minutes, which includes both MDs and associate providers, used to round for years at the hospital and gave up our privileges to do that about 3 years ago. So we have a full-time neonatal hospice service that covers the unit for us. And they will see all the babies that will go to deliveries, both normal delivery and C-section. And then they will come, the babies will be discharged, and we'll end up seeing them here. So what I'm going to talk about tonight is what we have done historically in the hospital, is where you meet the pediatric provider for the first time. And Ellie used to work in the neonatal intensive care unit, so she has a lot of experience there, and as I do too. That's my interest here. Southern New Hampshire is unique because it has a neonatal service, which goes down to 27 weeks delivery. Full-term baby is about 40 weeks. From a parent perspective, 37 weeks for a full-term medical perspective. So hopefully you're all enjoying your pregnancy and having a good time. And as a father of four, I always say to mothers who are in the room, if us guys had to do what you guys had to do, the world would be unpopulated. So I kiss the ground you walk on. So thank you for coming again tonight. And so the first time you'll meet us pediatric providers will be after delivery. And most of us round between 8 and 10 in the morning. And we used to have a baby, in the old days, meaning 20, 30 years ago, we'd have the babies actually in, much like you see on old hospital shows, in a exam room down the hall. The dads would be outside the windows with their cigars and would be smiling and pointing out which baby's there in the carriage. But now the mothers come into the room that they're actually going to be delivering in. And again, in the old days, you'd come into an exam room to be seen. You would then go to the delivery room, which is the second room, and then you go postpartum or post-delivery into a third room. So we've strained that a lot for the mother. And so we examine all babies in the presence of the parents. So I will walk through in a few minutes my exam, or come back to that, what we do with the baby. I brought my little doll tonight for festive reasons on how we examine the babies. But let's just walk through first maybe what we do, and then Ellie will take over after we leave the hospital and what we do when we get back to the office. So the first time we see the baby, well, as I said, will be first thing in the morning. We'll have a chance to take the baby out of the crib and do a head to toe exam, including the eyes and the ears, the heart, the lungs, and things like that. While hopefully having the parents see us do the exam. And often for the first time mom, it's fun to have them see us handle the babies, because unlike this real doll, your baby is not a doll. And we want to show, just how much care you can, and in looking after the baby, and how easy it is just to kind of hold the baby and don't worry about doing anything wrong. I like to say too, it's the blind leading the blind. Us parents have no idea what happens when the baby comes out. And similarly, we'll just do this together. From an OB to pediatrics, it's a great journey. So congratulations on all your hard work to date. So we'll examine you that first day, and then the next day we come back. As Dr. Silveira said, you can have an option to go home 24 hours later if it's a normal delivery because of maybe COVID, and would echo also that the pediatric provider also has a mask and a face shield when looking at the baby. There's also as soon as the baby comes out, there's a little band that goes on the dad, the mom, and the baby. And that serves as a safety net. So whenever the three are separated, or in terms of different tests we're going to talk about in a second, the OB nurse will come back in and verify the baby's band with the mother's band, so that we always know we have the right baby in the room. So then if you do stay for another day, we'll see you again. And then C-section typically is a 3-day course, but also some mothers are obviously going home at 2 days because of COVID. Hopefully that makes sense so far. So on the day of discharge, there's a couple things now that we standardly do, and I like to mention these just because it'll seem like there's a lot of things happening to your baby. But after 24 hours, there's a couple things we have to do to make sure your baby's well to go home. One is called the Pku Test, which is called, old mnemonic is phenylketonuria, which is a collection of about 23 plus diseases that are detected by a pinprick from the back of the baby's heel. And we drip it onto 3 little pieces of filter paper, or 3 little drops on a filter paper, which is sent to the state lab either in Boston or in Concord. It'll come back within a week of any mostly rare conditions, but include cystic fibrosis, galactosemia, and various, which is a digestive problem, and various other conditions. But it's mandatory. Your baby will not leave the hospital without that test. It takes about 5 minutes to do, and the baby's often taken to the nursing station to do that rather than do it in front of the parents. But you're welcome to attend that opportunity to see, but don't be alarmed if the baby's crying because you're having your heel squeezed at the bottom of the heel. They have a little Band-Aid that's put on afterwards. Number 2 is the hearing test. It's called the newborn hearing screen, which is a now mandatory test that we've done for probably 15 years. in all hospitals across the country to look for congenital deafness, which is inability to hear from birth. And it could be due to mechanical things or neurological issues. But it's rare, but it's important to do. So that takes about 5 minutes. Again, the baby's whisked off to a little closet over at Southern New Hampshire that I've seen. You're welcome to attend, but we don't have the parents in the room, but there's a little window outside you because you can watch your child with the Beats headphones on and have that performed. Those results will be done on 2 different occasions after officially 24 hours. Usually we like to do it at 48 hours. And if it's referred, or meaning the baby's test didn't come out as a pass, it doesn't mean the child is deaf, but it will be repeated, and hopefully that'll be then that'll be fine to send the baby home. If you do get a referral on that test, we then within 4 to 6 weeks like to do a audiology or hearing screen through the local hearing departments here at Southern New Hampshire. The third is so-called a congenital cyanotic heart disease test, or CCHD, where the baby has a little pulse ox or pulse oximetry, little gadget on the finger and the toes, and it measures how much oxygen is running around the bloodstream, and that has to be done after 24 hours, and again, it's mandatory. And we like to screen for things that in the old days we may not have been able to see, but it's a great way to prevent 7 major illnesses that we don't know about just from listening to the heart and lungs. And then the fourth test is something called a jaundice test or bilirubin test. And some of you may know what jaundice sounds like. Jaundice is not a liver disease like you might see in elderly people, older people. It's a test on the baby's ability to break down food. The liver is a recycling center of the body, like what I like to say. And in the first 24, 48, 72 hours, our liver doesn't work well. So blood cells that carry oxygen have to go, and for us, go to our liver and every 120 days get recycled. But in that process in utero or inside mom goes to the mother's liver, the blood of the baby is recycled and sent back to the baby to be used, to the baby grow. But once that cord is cut, the liver is on its own. So the blood cells that now have packed and are ready to get recycled go to the liver, and there's a little sign on the liver that says, I'm gone on holiday, don't come back in a few days. And that backup of red blood cells gets distributed in the skin and the eyes in a term we call bilirubin or jaundice. And so what we now do with a little strip on the machine, like a temperature probe, like you see now in the hospitals or at workplaces, it measures how much bilirubin or broken down blood cells are in the skin cells. And there's a graph that we use to determine what the level is in terms of high, medium, or low risk of increasing yellowness. Why do I bring that up? Well, jaundice makes babies sleepy. And if you're sleepy, then the babies don't eat as well. And if they don't eat as well, then breastfeeding particularly doesn't get started as well. So it's a quick test that happens in the exam in the mother's room, and the babies will be usually fine. In the old days, we would say, before all technology took over, we would just have the babies sit next to the window in the sun, and the sunlight and the ultraviolet rays would convert that bilirubin or jaundice into something that's peed out and pooped out. So you hear a lot about peeing and pooping as we go along here. That's our favorite topic for Ellie and I, because all babies do is eat and drink and poop and pee and sleep. Not enough of the last topic. So that's the PKU, the jaundice, the heart test, and the hearing test are the main tests. And then we get an initial birth weight, we get a discharge weight, and then we try to, again, examine the baby before you go home, answer questions about breastfeeding. I do circumcision still at Southern, so we could talk about that if there's a question on that. But then we'll send you home, and then with that, we try to arrange a follow-up within 48 hours to see one of us here in the pediatric department. So I've talked on long enough here for the moment, so thank you. I do provide strawberry daiquiris at the end of this for all of you to get you through after all, and then we'll be drinking too. No, just teasing. With that, I will defer to my wonderful colleague, Ellie, to talk about what happens when you get over to our offices here in Nashua and how we go from there. Thank you.
Well, welcome everybody. Chuck and I have done these Meet the PD nights for a lot of years. Chuck's baby doll is actually 25 years old or older, because that's how long he and I have been doing this, and that baby has attended every one of our meetings. So it's odd to do a Zoom meeting and not be able to see the audience. So it's a little quirky that way. So I'm one of the nurse practitioners here in pediatrics. I've been here for 25 years. We have a group of pediatricians and 3 nurse practitioners, and we've all worked together for a long time. People tend to come here and stay here forever because it really is a great place to work. And we really have kind of a team approach. When your baby is born and you get the good news that you're heading home, they're going to instruct you to call the office, the pediatric office of your choice, and get scheduled for newborn care. Here at Dartmouth, when you call in, they will have you connected with our secretaries, and they will take care of getting your baby registered and getting you an appointment. You may have selected a certain person to be your primary care provider, and if we can accommodate your baby seeing that person that very first visit, we certainly would. But sometimes that your person might be scheduled already, so any one of our colleagues would be happy to see your baby. Our goal is to get your baby in, make sure your family's getting off to a great start, and then we'll definitely work with you to get your subsequent visits with the providers of your choice. So we're going to see you on that somewhere in that first 3 days of discharge home from the hospital. When you come in, you would be screened at the door. They ask standard questions about fever, cough, symptoms like that. Everybody in the building wears a mask. We will allow both parents to come up with newborns. We do have some visitor restrictions here in pediatrics. For example, older children who are coming in, we try to limit just the patient and one parent, just to reduce traffic and exposure here in the building. But for newborns, both parents are welcome to come in. So we bring you up to the second floor. The nurses and all the staff here have a mask and a face shield. They would bring you back. They'll do a full set of measurements for your baby, get you settled in an exam room, and then one of the providers would come in. We will go through your history. We'll explore how pregnancy was, how did labor and delivery go, get family history, and ask about any questions you might have had come up since your discharge home. We're always asking about how your baby's eating, how are they peeing and pooping, and we also ask about sleep for everybody in the family because it's critical for all of you. Then we would wash our hands, do a full exam similar to the one that Dr. Cappetta will demo in a moment. And we'd go over with you any plan or recommendations we would have based on your concerns or things that we find for the baby. We'll show you your baby's growth charts. We have a computerized record, and we can show you the difference between your baby's birth weight, your weight leaving the hospital, your weight today, what that means. Most babies are born with a little extra fluid on board, so we give them a little bit of wiggle room. We'll kind of accept them losing up to about 10% of their birth weight before we get overly concerned. But we talk to you about all of those kinds of changes. And we'll show you the graph of how your baby's going. It doesn't have too many plots at the beginning, but we'll explain all of that. We are always available for questions. So after you've joined us here at Dartmouth Pediatrics, if you had a question when you get home, you're welcome to call back in. Our triage nurses are fantastic. They can answer most questions, and they're great at getting back to you much faster than the providers do. We're happy to call you back as well, but we know our nurses will do a better job of it. And if they have a question or a concern about your baby, they're going to come and find one of the providers so that you get the right information. We have a great booklet that our OB colleagues have written on newborn care, and we give that out to you at that first visit as well. We have nurses in the office during the day. Our urgent care colleagues do that in the evening and on the weekends. And then we have a nurse service on overnight. So we never want families to go home and feel like they don't have someone they can reach out to if a question comes up. The nurses do an incredible job cleaning every room. We have quite the complicated cleanup procedure here now, and they pay diligent attention to the scales as well. So we're making it as clean as possible. Currently in pediatrics, any patients who might have symptoms that would be of concern for COVID are directed to enter through our urgent care department side door. So as of right now, we're really limiting, so we don't have anyone coming to the second floor that we know has concerning symptoms for COVID. So I'm gonna turn it back to Dr. Cappetta, and he'll give you the world famous baby doll exam.
Well, thank you.
Oh, I'm sorry. I just had a question that came in and I just wanted to touch on that really quickly. So somebody asks, Dan and Amanda ask, so we don't need to schedule a baby's first appointment until after the baby is born. So when is the optimal time for scheduling that appointment?
So you would schedule after your baby's born, and the pediatric folks in the hospital would tell you your baby should be seen tomorrow, or your baby needs to be seen in the next 1 to 2 days. It can get a little bit complicated if you go home on Friday. We don't see babies in the office until Monday, but you could certainly give a call to the office on a Friday, and we'd be sure to get you in promptly on Monday morning. So that appointment will get scheduled after your baby's born, and the folks at the hospital will help you figure out how many days should it be before I take my baby in.
Excellent. Thank you.
No, thank you. And someone had a question about, can touch upon the process of where to go in the hospital and what to do for the first timers. Does, I think, does that, I'm not sure if that's referencing when you come into the hospital, and I would defer to Dr. Silveira, but I'm assuming you just go to registration and they would direct through the emergency room and they would direct you to labor and delivery. Is that correct?
Yeah. So basically, some of the semantics with COVID, I wish I had knew all the ins and outs, and I'm sorry if somebody has something that I can't answer. I'd be happy to find out the most recent protocols and get back to you after. But basically, if you enter the main entrance of Southern during the day, that's the one that's across from the parking garage on, I believe it's Prospect Street. Labor and delivery is just right down to the right. So that's the typical way in. At night, in the past, you know, the people right there could buzz you in, but I believe nowadays with COVID, they're still asking like night and weekends for you to go through the ER entrance, which is on the other side of the hospital. But I would have to kind of double check some of that stuff. But again, the birthplace is on the main level of the hospital. And basically there's a door you walk through and a waiting room that's sort of closed because we don't have any big families waiting anymore. And then there's a phone that you pick up, and then that buzzes the secretary, and the secretary will then let you in, and the secretary will take you know, your name, insurance information, stuff like that. Most of the time we have an FYI that's coming, because we do recommend that during the day for anything we're urgent, that you call our office. Also the same for nights and weekends. We always want you to call the 577-4300 number, and then the operators will page the provider on call if it's a night or a weekend, or during the day a nurse will get back to you. Even if you think you're on the way to the hospital, we still recommend you just call and you page and you say you're on your way in, and that way they do. They have your name, they have your, they can pull up your medical record number and print it and have everything ready in case you're about to just deliver when you come in. But so yeah, most of the time we have an FYI that you're coming, but the secretary will meet you right there, take any information that's needed, and then they'll direct you. Usually it's to triage first. So Southern has 4 triage rooms, and that's where the provider will see you, address your concerns, whether it's labor, checking for labor, or whether it's, you know, pain and we're not sure why. Maybe it's a kidney stone, maybe it's something else. So we see you in the triage area if it's a visit where we're like, okay, you're not in labor, or we figure out your pain and then you're more comfortable and can go home. then you'll just go home from triage. But if it's time to admit you, then after being in the triage area, you'll move to your room. And as Dr. Cappetta mentioned, it is a labor, delivery, and recovery called LDRP. Other hospitals have what's called labor, delivery, and then postpartum. So you would do labor and delivery in one room and then get moved and postpartum in a different room. Here, you do your labor, delivery. They do clean the rooms between, because we know delivery can sometimes get messy. And then you would postpartum in the same room the whole time, which is kind of nice that you're not having to move rooms.
No, thank you. That's great. Thank you. And yes, I mentioned in my bit, I forgot to mention, yes, before the baby goes home, we will obviously need the car seat to be with the parents. The question here, can dad leave the hospital to get the car seat, or should we bring it in when we go to labor and delivery?
So they're asking now that if you're just going in for triage or something and you really don't know or think that you're going to stay, I think you can just leave your car seat and then go back and get it. But if it's, you know, pretty much a labor check where you think you might be staying, or you're coming in for an induction or something like that, they're just recommending that you bring it in with you so that you don't have to leave the hospital and come back.
Yes. Yeah, and for babies who are born prematurely, less than 37 weeks, and depending on the weight of the baby, there may be a car seat requirement, the so-called car seat trial. These are babies that are particularly in the NICU or neonatal intensive care unit. So that's weight-based, and that'll be, they're basically placed in there for up to a half hour sometimes, just to verify that it's a safe area, safe transport home, and that they can maintain their oxygenation or oxygen in their bloodstream. So most babies will pass that. Above 37 weeks, you don't need to do it because we assume everything's fine there. So hopefully those answer those two questions. Great questions, thank you. So if I can, to bear with me, I'm gonna just move my screen for a second because I'm gonna try to figure out how to best to show our baby here. This is our newborn that we got at the old Toys R Us on Daniel Webster 25 years ago, as Elliot said. When we first meet the baby, the first thing we talk about is, I'm going to go head to toe, but it can be an all over exam. And especially if the baby's quiet, we'll start with a stethoscope and listen to their heart and lungs here, in their front, on their back, things like that. But once that happens, obviously the baby usually wakens. We will unswaddle the baby. The baby's swaddled with a little blanket in the hospital crib there, or bassinet. But we feel the top of their heads. We call a fontanelle or window. There's two of them. There's one here that's a diamond shape that closes about 18 months. This allows the baby's head to grow up until about 3 years. And there's one in the back, which is a triangle shape that closes at 6 weeks. So each specialty has a so-called handshake. So if you see two pediatric providers, I won't show on Ellie tonight, but I would come up to her head and tap her head just to make sure her windows are closed. I don't know what OB does for a handshake, but that's the inside if you want to know that. Another attempt at a bad joke. I don't see Dr. Silveira laughing as much, so I'll keep going. So we just check that, and it's what's freaky for parents too, for first-time parents, is when the baby's really quiet, this little window up here can be a little sunken. And so you can actually see the baby's heartbeat. We call it soft spot, not because you can actually put your finger there or hurt the baby by touching it, but you actually can see the pulsating heartbeat go like this as the baby's sleeping. When the baby's crying, you may see the concave go from this to this. It's just because there's more blood flow going through, and that's a good sign. But as I said, it all allows the developing brain to grow inside the skull. We feel around the sutures or the landmarks of the scalp. There's 6 different bones that come together to form the baby's head. We'll do that as we're talking to the mom or dad in the exam room or in your room. We'll look at their ears. We might look with an otoscope and earpiece equipment to look in that, but most of us don't. We tend to do that when we get back to the office. We look at their eyes with an ophthalmoscope, and we look for something called the Red Reflex, which is in the old days when we went to Walmart to get our pictures developed, you'd come back with your film and they'd have little red spots in your pictures. And what we're looking for are those red spots. It doesn't say anything about the baby's vision. It just says that the connection between the front of the eye and the back of the head, which interprets our vision pathway, are working. But we don't want to see something called a white reflex, which is so-called cataract, or a glaucoma, which is an older disease, but you can rarely see those in kids. We feel their nose. Sorry, I'm doing this in front of the camera. So we feel one side, feel the other, and we don't want to go, but we just want to make sure that air is passing through both sides of the nostrils. Babies are obligate, or meaning have to breathe through their nose for the first 3 months. So their mouth is an ornamental window piece. Obviously food goes in, but air does too. But you'll notice when babies are stuffy, and particularly in the winter months coming ahead, that they won't feed as well, or they sound like Darth Vader from Star Wars, very grumbly, because they've got their nose all clogged up with a little cold. We could talk about cleaning that another time if you want. We take our gloved finger when you put it in the roof of the mouth to feel the roof or the top of the inside of the mouth, and we get a sense of their suck reflex, which is a natural innate thing that babies will start to do as the moment they come out of mom. As I said, we look at their ears. There's a straight line connection from the top of the ears to the side of the eyes here, and that stays with us through life. There's some different conditions we call low set ears that are associated with kidney abnormalities, but again, rare. But we just are checking that in our general gestalt or awareness of the baby. After listening to the heart and lungs, we move their arms. She's a little stiff. She says hello. But then turning sideways, if you can see this, we are now going to be feeling their belly. We feel for their liver and spleen. Look at their belly button, which OB will clamp off and with a yellow clamp, which has a special gadget. You will not be able to cut that off with any kind of equipment except for this special gadget that Dr. Silveira has or we have in the office. So don't be alarmed if you can't try to open it up. It's purposely clamping or shutting down the pathway of blood through the placenta and the umbilical cord that fed the baby for those 9 months. But once the cord is clamped and the clamp comes off before you go, it takes about a week to look better. We then examine their hips, which again, just for the sake of examinations, what we want to do is the hip is a ball in a socket. And what we're trying to do is check that movement of the ball within the socket of the joint. Much like the rotator cuff of the shoulder that goes like this, so too does the hip bones. So what we're doing is examining the baby such that you can actually, what we're trying to do is bring the legs to the side of the bed. And for the sake of us adults in the audience, if I did that to any of you, we'd be in the orthopedic ward and not in OB or pediatrics. But for babies, they're very flexible and can do this because the ball of the hip needs to touch the side of the joint in order for the legs to grow equally and worry about arthritis and other things. So that's part of the exam we'll do routinely in every baby up until about a year. We then turn the baby over and look at their back. We look at their little butt crack here. And what we want to make sure, the body is a bookend. We have a left page and we have a right page. We want to make sure the spine, which goes down the middle, is all there. But we don't want to have a hole or a dimple right here that's too deep. Because that can potentially lead to something called spina bifida, where the spinal cord is involved and other things can happen. Forgot about the genitalia. In girls, we look at their labia, and the boys, we check for downgoing testicles. Sometimes the testicles may not be easily found in the scrotum or sac, but we call that bashful testes, and they just kind of on a little bungee cord will be coming up and down, but we'll examine those frequently in the first year of life. And as long as we can find 2 of them within the scrotum in the first year, we're good. If we can't find it, we may do a little ultrasound down there to see what's happening with time. So now that exam, which takes about 5 minutes, just talking about it, I will do in a period of about 2 minutes for the sake of the parents. Again, not holding them next to my shoulder, but just for the sake of, just showing the family that babies are going to be perfectly comfortable just holding, always supporting their head, because babies are floppy and they'll just go like this. So when you pick up a baby, always start with the most important is the V of your fingers and hands supporting the head, and then the rest of the body can come along elsewhere. There's different ways to hold the baby. There's so-called football. I always like holding like this, but other babies can be held like this or this. So you'll just get used to holding your beautiful creation and just have fun. There's no right or wrong. And as long as the baby's not crying, that's the best. But they'll cry for all kinds of reasons, most of which none of us will know why. So hopefully that's my little walkthrough of the exam. And with that, I think we'll go back to maybe Ellie can talk about after we see you, those first few days, what happens next.
So when you come in, we check on how everybody's doing. We'll explore how your baby is feeding and see if you have any questions or concerns about how that's going, whether you're using all breastfeeding, bottle feeding, some combination of the two. We reassess any concerns about jaundice. Sometimes if your baby still is a little bit jaundice when you come to the pediatric office, we might do a repeat check of the bilirubin. And in our office anyway, that involves a blood draw, which our colleagues in the lab do for us on a regular basis. So they're pretty skilled at doing that. We don't have the wand device that they have at the hospital. And we don't do that very often, but we certainly can repeat that check if there's a need for it. We see your baby in that first couple of days after you go home, and then as long as things are going well, our usual plan is to see you back at about 2 weeks. And at 2 weeks, we expect to see your baby right around their birth weight. So either at or right under birth weight, that's kind of the goal. If between the first visit and the 2 week visit, you have a concern or we just want to see your baby back sooner to make sure breastfeeding's taken off or weight gain has begun, sometimes we squeeze another visit in there between those two. If things are going well at the 2 week visit, then we move you on and we start the regular well child visits, which for us initially are at 2 months, 4 months, and 6 months. And it's at the 2 month visit that we start your baby's regular babyhood vaccines. You will be offered the hepatitis B vaccine for your newborn at the hospital. And as long as that's been done there, then your first round of vaccines are at the 2 month visit in the pediatric office. And at those visits, you get a full set of information pages about each vaccine, and we talk to you about each one. We are pro-vaccine here at Dartmouth-Hitchcock Pediatrics. We believe in their safety and that they do benefit your baby. But we're always happy to talk to you and address any questions or concerns that you have about vaccines or what's best indicated for your child, your family at that time.
Good. Oh, excellent, excellent. Does anyone have any questions about another favorite topic of ours is pooping? It's something that once you have a baby, you won't talk about, obviously, an adult, you don't talk about poop a lot. But as a pediatric provider, that's all we live by. So in the hospital, we like to see the babies poop and pee within the first 24 hours, not for anything other than knowing that the pipes are working. The first poop or stool will look like black, tarry, thick junk, if you will. That's a great medical term, but it's great for leaking roofs. So if you want to save it, you can apply it at home in the middle of the winter. But otherwise, and that often is confused as, oh, the baby's pooping, so everything's working well, and it's still that black tarry stool. That's just leftover from 9 months of feeding inside. But once the food starts to come in from above through breast or bottle, then the stools will start to turn different colors. The first is a yellow seedy, like Grey Poupon, that you put on your toast and never eat the same again. And then it may be turned green, it may be turned blue, it comes definitely orangey. So there's all colors of the rainbow. The only color we don't like is red, which often is reflective more of a straining phenomenon when the poop is trying to come out. But babies can typically poop 3 to 4 times a day or every single feed, or believe it or not, once a week. So for me, Ellie's heard this before, I will emphasize the triple P's, a poop paranoid parent. I don't want you to become, because that just, it means that they can poop 10 times a day to once a week, and that's normal. We try not to use the C word or constipation. Babies will have a different transit time, as it's called, breast or bottle. Breastfed babies may have more poops than bottle fed, but it really depends on the baby and how frequently things are going in. But we'll be there to answer those questions. We won't change the diapers unless you ask us, I guess, but it's all a good thing. Peen-wise, again, in the hospital, we'd like to see some frequency of peeing. The nurses will tell you, at least 3 or 4 wet diapers, things like that. The new diapers all have little lines down the middle, so you can actually tell when they turn blue, you'll know something's happened down there of some kind of load, and that makes it easy. But again, for me personally, I don't get excited too much. As long as I know what's going in, I know it's going to come out at some point. That's why Ellie and I have that different color hair on the top of our head versus Dr. Silveira's, whose hair looks a lot less gray than ours. No, but it's a wonderful team with the OB department. So the other thing is, what was I going to say?
Let me talk about feeding.
Feeding, yes, thank you. Good job. Good transition.
So we'll go back to the top of the system, and we will explore with you at every visit how your baby's feeding. And some families choose to breastfeed, some families choose to bottle feed, and we'll support you in whatever your decision is. Breastfeeding has a lot of written material, and there's a lot of information about breastfeeding, which is helpful, and that's great for parents to be prepared. Keep in mind that the baby pays no attention to the breastfeeding class, doesn't read the book, and doesn't watch the video. So breastfeeding is fantastic. You will never hear one of us say a negative word about breastfeeding, but it is not always as easy as it appears. So not to be discouraged if you're trying to get breastfeeding going and you don't know how much your baby took in. You don't, because there's no way to measure that. And early on, it takes a while for the milk to kick in. Some of that might be influenced by how labor and delivery has gone, or if you had a C-section. So not to panic, not to get discouraged. Listen to your nurses, your OB providers. They do have lactation consultants available at the hospital who can assist with breastfeeding. And we're happy to answer those questions over here as well. But I just really always want breastfeeding families to know it's not as easy as it sounds when you first hear about breastfeeding. And if you choose, or for some other medical reason, your baby needs to bottle feed, the formula is safe. We'll review with you how to prepare it, what kind of volumes to offer. Babies have a need to suck. So sometimes they've taken their bottle feeding and they've had a couple ounces, and then they're still looking around and their mouth is going and they look like they're hungry, but they're probably not, because their tummy's really only about that big. So we talk to you about ways to help you soothe your baby, or have your baby over time learn to self-soothe. It doesn't always mean they need another feeding. Feeding method decisions are very personal, so parents should make those decisions for their families. And of course, all your friends and extended families have made those decisions too, but they made their decision, you make yours, and we're here to support you in what you feel is best for your baby.
Correct.
What else do babies do, Chuck?
Well, I was going to ask Dr. Silveira, can you talk about what happens at about 36 weeks in the group B strep discussion? Because that's a big topic for us in pediatrics.
Oh, yeah. So at the 36-week visit, we're usually seeing you around that time, 36, 37-week visit. we do something called a Group B strep swab. The only time you wouldn't have that swab at that visit would be if on your first urine, very early pregnancy, we get a urine at that first visit. If that Group B strep bacteria is growing in your urine, then we consider that to be positive for the whole pregnancy. Otherwise, at that 36-ish week visit, you will have the swab. And the swab is just a little tiny Q-tip that gets placed into the vagina through the opening about a third of the way, kind of rotated around the vagina. It then moves between the vagina and the anus. That's called the perineum, just on the skin there. And then per, CDC protocols, not because we want to, the little swab does have to just go through the anal opening. And that's it. It comes out, the test is done. The swab is then sent to the lab, and they're looking to see if a bacteria called Group B strep grows. It's a normal flora. We all have bacteria that grow on our skin, live in our vagina, and that is one of them. It's normal. But it has been shown to potentially cause babies to get very sick. And it's pretty rare, but it's something that we can pretty much prevent and make a never event if we screen for it. So if we screen for it and we know that you happen to have that bacteria growing there, then we will recommend that you get treated with an antibiotic. When the water breaks, if that happens before labor, we start it when the water breaks. Otherwise, we start it during labor when you're in your active phase of labor, or the process where we think baby's going to be coming within the next 4+ hours. Ideally, you get not only the dose, the first dose, it's usually IV penicillin. If you have a penicillin allergy, then we have other protocols for antibiotics to give you. But usually you give one dose and then you repeat it 4 hours later for ultimate dosing. But again, I like to inform people because sometimes women will then worry that, oh my God, my labor happened so fast that, you know, I barely got to the hospital, never mind got 2 doses 4 hours apart. That is optimal treatment. But again, the GBS sepsis for baby is fairly uncommon and almost never now that we screen. And if the baby's coming that fast through the canal, it's probably not going to get super sick and coated with so much bacteria that it's going to cause a problem. And Dr. Cappetta can talk more about, you know, what they do in the hospital if you were GBS positive in terms of monitoring babies and whether they got, you know, perfect ultimate treatment of the 2 full doses or maybe only 1 dose and the baby was born an hour later.
Yeah, so typically if we like, as Dr. Silveira said, we like to have 2 doses at least 4 hours prior to delivery, which would fulfill our requirement to think that anything that goes to the mother would then go to the baby to get protected, because Group B infection in babies is quite serious, and it doesn't present with a fever. It doesn't present with, like you and I might have, a runny nose or sore throat, which is also the same organism for strep throat. But it can just present in babies in subtle ways of difficulty in feeding, not soothing, not acting right, too sleepy. So very sort of things that are subtle, but enough that gives us a little angst at times. So most babies are perfectly fine having that protocol. But if the protocol right now, if you delivered and didn't only had 1, is the recommendation is to stay for at least 48-hour observation. So we would keep you for 48 hours, which coincides with your normal 2-day vaginal delivery anyways. If you're there for C-section, typically 3 days, then that works fine too. Some OB departments, because I round in different hospitals, if you're having a C-section, you're not going through the birth canal, so you'd get another antibiotic called Ancef that just covers you for the OB surgery perspective, and that would be fine from a Group B strep analysis. But these are probably more details than you need to know, but it's something that for us we like to know, and we also get the OB history and take that seriously about what infections the mother had, any other exposures to things, because it gets some other baby unit that goes on. But thank you for that, Dr. Silveira. Any questions at the moment? I don't see any pending here at the moment.
One question just came up that we'll address, but I was also asked to talk a little bit about postpartum care for mom.
Yes.
So when you're in the hospital, you do see a provider every day. Again, because of the collaborative nature with the hospitalist, it's usually one of the hospitalists that sees you nice and early in the morning to check in on you, make sure your bleeding's appropriate, you know, talk about whether or not you're having some trouble with breastfeeding, see how you're feeling emotionally, make sure your fundus, the top of the uterus is kind of coming down appropriately as it should be after the delivery of the baby, that you're not having too much cramping. If you had a C-section, obviously we want to make sure your pain is taken well care of, looking at your incision, no signs of infection, nothing else concerning going on. During the hospital stay, they will do a depression screen. If you score high, they do alert the offices, and we make sure we reach out to you right away and schedule another appointment to see you and talk to you about things, whether it's in office or by Zoom, because we are doing more telehealth appointments to check in on you. And otherwise, if you're feeling okay, typically we give you precautions in the hospital about what to call for, and then see you back for a routine 6-week visit. For an uncomplicated birth, we are offering again telehealth visits if you don't have any concerns where you need an exam for that postpartum visit, which, you know, some of COVID has brought telehealth appointments, which can be very helpful for people. And I will tell you, with a baby, trying to get out of the house in time for an appointment can be very challenging. I found it challenging and understand why people are running late. So actually, if it's appropriate to have a telehealth visit, that can be nice, because then you don't even have to leave the house. And I often, you know, can still connect with mom and say, hey, can you just at least show me baby? Because now when you come to the office, often you're leaving your baby at home and I don't even get to see baby at 6 weeks. So it's kind of nice to be able to at least see baby on the phone. But we still, you know, can see if there's any concerns about the incision, obviously, whether it's a C-section or a vaginal incision not healing right, can see you in the office. That's totally appropriate. Or if you have to come in anyway for a glucose test because of gestational diabetes and we're checking again at the 6 weeks, or you want, you know, an IUD or an Explanon or something like that, you know, place that. With the postpartum visit, we're often, again, talking about, you know, doing a depression screen, seeing how you're doing. Postpartum blues are common. But at the same point, the way a woman feels after delivery is very individual. And as I loved how Ellie put it about, you know, your friends and your family, and everybody has their own ways that they felt, and it's not you. So you have to be in tune to how you're feeling, but do be open to having friends and family comments about things. And if it's getting to a point where you're not enjoying taking care of your baby, or your thoughts that women never ever think that they're going to think that they wouldn't want their baby to wake up, or what if that pillow was just a little closer to the baby. Nobody ever thinks they're going to think that way, but if that's anything like that starts to infiltrate the mind, like, you have to reach out right away. It's not you, it's a biochemical malfunction that's going on. We are here for you 24 hours a day. I've received those calls in the middle of the night, and I'm glad I am on call to talk to you. But even if before the postpartum visit you're just not sure about how you're feeling, we want to see you, we want to talk to you, and we're definitely going to talk to you about it at 6 weeks. Being a new parent is hard. I don't know, I have a 5-year-old and a 3-year-old, and I still find it hard. I'll tell you, it is the hardest job I have ever done. Like, I think medical school was hard. Yeah, it was. Residency was hard. Yeah, it was. My job, it's hard. Yeah, but actually being a parent is literally the hardest thing I've ever done, and every day is different, and every day poses a new challenge. And so it's amazing. I love it. The things that my kids do and say, it just brings a smile to my face. But that's not to say there aren't times that I'm just like, how do I deal with this now? And everything you read is, yeah, timeouts are good, timeouts are bad, this, that. So parenting is challenging. And there's definitely ways to deal with it. You can talk to us, you can talk to family, you can talk to friends. I've found support groups. There's many different support groups in the area. I happen to live in northern Massachusetts, and there's a a great free community support group that offers support groups for moms, support groups for dads, various, play dates through the library for book readings, or at least even with COVID, you can sort of see that you're seeing other people. And yes, their house is just as messy as mine. No matter how hard I try to pick up those toys, their houses are at least just as messy as mine. Nobody has a sitcom house or a sitcom life. So I found that helpful. But yes, parenting can be stressful, it can be hard, and it can be very emotional. And sometimes women do need a medication to help. It doesn't mean you have to be on the medication for life, but sometimes you need it to smooth things out, to get you past the rough spots, and we're here for you if needed. We're also here to talk about counseling. And not to say you need medication, but maybe to talk to somebody else to figure out where the stress is coming from. What are some other things you can do? How can you carve out time to exercise? How can you carve out some time for yourself? Again, things are harder now with COVID, so it's hard to say that. Like, I used to have my parents come help me so I could get some notes done during the day, and they could help with my kids. They can't do that anymore because my parents are higher risk, and I feel like I'm higher risk. So I get it, we all get it, and we're here to help you through it. So I want people to know that. And the other big thing about the postpartum visit is figuring out contraception. I always like to start the contraception discussion in pregnancy because, again, once you have your baby and you're not sleeping as much and you're like, that's the last thing I want to try to decide on. So I like to try to do it in pregnancy when you can kind of think you have a plan in place, but sometimes you don't, and we're here to help you figure that out after, whether it's condoms or whether it's deciding on an IUD. You have a lot of different options, and we're here to find the one that works the best for you. So if there's any other postpartum questions, please feel free to ask. And also, Dr. Cappetta, Ellie, please feel free to add to the stress thing about sleep and baby and how to deal with that best, because I know you have probably a lot more experience than me, both as a provider and as a parent. So
over time it gets better, but unfortunately we don't have any insight into when that time is going to be. I often say to people, 4 hours. If you can get 4 hours of sleep straight, you can rule the world. And before you're a parent, that sounds like craziness. But once you're a parent, that makes sense. So, I think all of parenthood, you got to cut yourself some slack, but definitely in that just home from the hospital postpartum phase, this is what sweatpants and somebody's spaghetti sauce left on your front step for you to just heat up later. That's what really has to happen now. Like, just chill out, cut back, don't worry about this stuff. You'll get to it at some point, and just relax. Enjoy your baby, get things going off to a good start, and reach out to any of us if you have a question. And we're here for moms too. So if you're in seeing us for one of your baby's visits and you're starting to feel like you're having some thoughts or feelings or things just aren't going the way you thought this was going to be, we are more than happy to listen to you, try to give you some supports, and by all means get you routed back to your providers in the OB department.
That's right. Well, thank you. One great question here about strategies about keeping baby from some close family while not going well in this times of COVID. And do you have any ideas about that? I think it's a new world. We all know this. We're saying this every day. It's a new world for all of us. I don't think there's a right or wrong way to look at this apart from, I think one term people are using now, the bubble. Determine who's in your bubble. Initially, it's just the mom and dad and baby. And then the mom and dad and baby live next to grandma. So at some point, maybe grandma and grandpa will come over, like Dr. Silveira just said, and be allowed in the bubble. That sounds funny to say allowed in your family, but we just don't know enough about what's going on and the risks. And you don't have to be coughing. You don't have to have a fever. You could just be a silent spreader. So I think it's just very personal topic too. So, you start with that incremental core group, and then over time, many parents at 6 weeks have allowed that bubble to expand. And then at 8 weeks, 10 weeks or whatever, then the uncle might come over. And so we've lived this now 8 months. So I think it's just it's an evolving discussion here. So if you're living with your grandparent, your family members, then that bubble immediately from the get-go is probably going to include them. But the neighbor, the friend, the buddy, you know, those people just have to acknowledge that you've got a newborn, you know, his immune system is going to start to rev up here, and anybody with obvious illnesses of, you know, like coughing and sneezing, I would keep away, but also grandparents who have immunocompromised, cancer therapies or meds that put them at risk. I think we'd all advise just to minimize that exposure as much as possible. Wear a mask, have the drive-throughs. You know, a lot of grandparents have told me they've just sat in the driveway and the baby brought to the window. You know, is that fun? No, that's not like how we wanted it, but it's reality at the moment, and hopefully it won't last, you know, longer than we want it to, but we just have to take those extra precautions. So I don't know if I answered it, or Ellie or Sharon had any additional comments, but I think you just have to be honest, and hopefully they'll understand that as first-time grandparents, you know, they get it and they don't want to, you know, do anything for the baby.
Yeah, and I would just add, if you do allow someone in to meet the baby, make sure everybody who comes in washes their hands really well with soap and water. And you know, typically you want them to do that for a good 20 seconds. And then it's up to you to decide if you also want to have them wear a mask. And I agree with Chuck, anybody that has any symptoms, you know, right now is not the time to take those chances.
Yeah.
I would agree. I think it's challenging and it's hard, and I see it from both perspectives. You know, I can understand the grandparents wanting to be there and to hold their grandbabies. I've seen how hard it's been on my parents. But then I've had that struggle even thinking about it myself, you know, but if anything were to happen, then they're not getting many more years of seeing their grandkids grow up potentially. So I've made the decision to see them a couple of times this summer outside. They are wearing masks and my kids are wearing masks, which was hard with the 3-year-old. She's almost 3, so earlier in the summer it wasn't happening as much, and later it was. But making, you know, having social distance outside with masks as much as possible. I'll be honest, I was nervous for 2 weeks after. Everything's been fine. But I think the big thing that Dr. Cappetta was saying is you have to know the bubbles, because if you're working from home and you and your husband are very good about wearing your mask every time you're out and hand sanitizers and everything, you know your bubble, you know your risk. But then you really have to understand the risk of anybody you allow in your bubble. Because you have to know, are they eating out at restaurants, and how comfortable are you with that level of risk, or who else are they seeing? Because everybody they see is expanding their bubble. So if they're the grandparents and they're basically at home like you, and they're just making sure that they're not leaving the house too often, and when they do, they're doing everything appropriately, then maybe you feel that there are people that can be in your bubble, versus somebody else who, you know, maybe did just decide they have their kid coming home from college and, you know, various other factors that are going on. So I think it's very individual, it's very personal, and we're all just doing the best we can.
Yeah. No, great points.
There is a great website for reliable COVID information. The Children's Hospital at Dartmouth has a webpage for parents. It's called chadkids.org. And it has a lot of pediatric information on there, but it has a tab specifically for COVID resources. And it has links on there for pages that might update really frequently, like the Center for Disease Control or the State Health Department. But it then also has just a lot of other really pertinent, up-to-date pediatric-related COVID information. So if you're looking for information on the web, that's definitely one place you can start and know that you're getting accurate information. And you don't need to be our patient to go there and look at it.
Right. And the American Academy of Pediatrics, AAP.org, also has a great website. Again, it's parent driven by pediatric specialists, and the public. It's a great place and to go to. And here we are doing an internet meeting, but we're all saying every day to the kids, get off the internet, and yet this is a resource that I would go to. It's reliable, it's trustworthy, it's not, BuzzFeed, things like that. So ask us, we're here to answer any and all questions, day or night. I will actually echo too what Dr. Silveira said about OB coverage is our pediatric offices are open 8 to 5, on the 8 to 7. Now at night, 8 to 6 maybe, sorry, Monday through Friday, and we used to do weekend hours, we don't, but after that time, there is a 24-hour hotline that takes us to the next morning. So you call the 577-4400, which is our pediatric department number. They would put you on into the system for pediatric trained triage nurses, which follow national standards. They're just not a mom or dad answering at home. They're following protocols that are approved by pediatric providers across the country. And then if they had questions, they would call the provider on call. And so that's on the weekends too. So our urgent care hours are 8 to 4.
I think they were only open until 2 now.
8 to 2 on Saturday and Sundays. And during that time, prior to COVID, you'd be able to get seen down there. And if they had questions, they'd call the pediatric provider on call. But then after 2, this same triage system kicks in, and they're great. And they're well served, and they take questions all the time too. So, like OB, we're there to help you and get through this times. So seeing if there's any other questions there.
Are there any other questions that anyone would like to ask? All right, I'll turn my video back on. I think you're going to hear the baby because that's COVID times. This is messed up. So I know we're cranky. So I just wanted to thank everyone for being here tonight. Thank you again to our providers for presenting. I think that's been a lot of really great information. So thank you. And if anyone has any questions, I'll send out a follow-up email tomorrow with all the resources that were provided tonight. And feel free to send me an email back if you'd like me to get you in touch with any of our providers from tonight's presentation. Again, there's going to be a survey at the end, so please fill that out. Again, it helps us with programming in the future. With that, any final words from our providers tonight?
Thank you for joining us, taking the time out of your night, and just remember we're here for you through pregnancy, through delivery, through having your baby, and into the future. So thanks again. Congratulations. This is an exciting time, and please let us know how we can help.
I would just say congratulations and good luck, and it's just the most wonderful, most fun adventure you're ever going to go on.
Oh, enjoy. Thank you. Thank you for putting up with us all trying this for the first time. So this is great. Great fun. Thank you.
Wonderful. Well, thank you, everyone. Congratulations and good luck on your delivery and your expanding families. And we wish you well from Dartmouth-Hitchcock Health. Have a great night.
Hey, everybody.
Bye.
Bye.
Bye. Thank you.